Lori Doyle is in the waiting room, but she wasn't able to put the bill number in. So she just asked if we could let her in.
Okay. Okay. All right, good afternoon. Welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We have 3 bills to discuss today, and the order of the bills is House Bill 919 will be first, and then House Bill 601 is second, and House Bill 565 is third. And we have heard all 3 of these bills. We've had discussions about all 3 of these bills. So we are hoping that what we bring you today is the result of your good discussion and information that you're going to be able to support and move forward. So I'm going to start with House Bill 919, and let me explain. This subcommittee voted positively on this bill last Tuesday. When we took it when we were going to take it to the full committee, it became an issue was raised that perhaps if an ASO who was not meeting its obligations under its contract was fined, then those costs could be passed along to the health department and for anyone who is getting supported by Medicaid. So we wanted to make sure that we were not fining ourselves, basically. And so Lisa Simpson did a lot of work with the MIA, and we believe we might have the language now that makes sure that doesn't happen and it addresses it appropriately. So Lisa, will you tell us about the changes in House Bill 919, Maryland Insurance Commissioner Specialty Mental Health Services and Payment of Claims Enforcement?
Sure. So the reprint in your packet as adding language to address the issue of possibly state money being used to pay interest and different examination fees. And all of that is subject to the, it's in the discretion of MIA. So basically the uncodified language at the end of the bill is asking or is directing the MIA to take into consideration whether state funds could be used in paying these penalties or interest, and if it will be used, then to not impose or not to require the payments of the interest or the fines if state money would be used. The uncodified language also is requiring MIA, when they investigate a clean claims complaint, to give the results of their investigation, that information, to the Maryland Department of Health. And the information is also directing MIA, if they conduct a market conduct study of an ASO, to provide our committee, finance, and also the budget committees with a copy of the market conduct study.
Okay. Are there questions about the changes? Or actually, let me ask if anyone from MIA wants to speak to this. Michael, are you raising your hand? Because I don't have my participant panel up yet. Here we go. Oh, no, that's not what I wanted to do. Sorry. I have Lori Doyle.
Thanks, Madam Chair. And I want to first off thank the subcommittee and the full committee for your support of providers during this troubling year, almost year and a half. So I have a question about how this works in reality, if I could. So the ASO is subject to 2 provisions. It's subject to the insurance article that we're talking about here, the late payment article, and it's subject to terms and conditions of its contract with the Department of Health. So if it violates or otherwise does not meet the deliverables of the contract, it is subject to fines and liquidated damages. Those are not required to be paid with non-state funds. It's just you pay the money back. So I guess my question is, if the MIA were to conduct a market conduct exam or otherwise fine or penalize the ASO, how do they know what pot of money is being used to pay the fine. And if the ASO says, well, we're using whatever, we get paid by the state, that's what we're using, do they just then walk away from the fine? So I'm just trying to figure out how this works in real life. So thank you.
So, Dan, I know that you were able to see the contract. Can you address Lori's question?
Sure, I think I can. So the way, I mean, obviously, what the MI would do in the event that it finds a violation is, it could potentially issue a penalty to it. It also could potentially require it to pay the interest that is required under 15-1005. In either event, we believe that contractually, the ASO would not be able to then charge the state for those additional costs that it has incurred as a result of its own violation. So, and we think that, the changes that Lisa has done, makes that clear as well. So, there's sort of a belt and suspenders approach to the bill as it's drafted now. We think some of the language may not be technically necessary, but it makes it clear that the ASO is going to be responsible for those costs.
Does that help, Lori?
I think so. So if the ASO pays out fines or other penalties, they can't then come back to the state and say, well, you owe us this money. Is that how that works? Or I'm just.
That's the intent of this bill, yes.
That's correct.
Okay.
Thank you.
Okay. All right. Are there any questions from the committee on this bill? Delegate Bagnall.
Thank you, Madam Chair, and thank you for all your work on this. I know that this is the culmination of hours and a couple of days of work, intense phone calls. If you could just speak a little bit to does this strengthen the enforcement of the enforcement capacity of the MIA? I'm just trying to fully understand the implications.
So in my impression, it does. Does anyone, because what it does now is it gives MIA the authority to do the investigations on all the complaints. It also gives MIA the authority to do a market conduct study. I understand they're prepared to do that. And they will be reporting the results of their investigations to MDH, who will then be, asked to resolve them, and they will get information on, what the complaints were and how they were resolved. So, and the fact that they can actually implement fines and penalties gives them the enforcement that we are looking for, without charging the state.
And just a follow-up question, potentially that doesn't impact the timeline on how quickly we can, is that correct?
This is an emergency and legislation, and they're ready to get started as soon as the governor signs the bill.
Thank you, Madam Chair.
Okay. Any other questions? Thank you for your work on this, Delegate Bagnall. Seeing no other questions, I'm going to I need someone to move the amendments.
Move the amendment.
I got a motion. I got a second.
Second.
Anybody need to discuss the amendments? Seeing no hands. If you need, all those in favor of the amendment say aye. If you need to vote against the amendments, please raise your hand in the participant panel. Seeing no hands, the amendments pass unanimously. Can we have a motion on the bill?
Move the bill
As amended.
as
Okay,
amended.
I got a second. Anybody need to discuss the bill? Delegate Bagnall? No.
Thank you, Madam Chair. Just a quick question. Are we already talking to the Senate about how we would conform the Senate because the Senate crossfile has already passed out?
We haven't talked to them specifically about this, but I don't think it'll be an issue.
Okay, thank you. Thank you, Madam Chair.
Thanks for raising that. Okay, anyone need to vote against this bill as amended? Seeing no hands, the bill passes the amended bill passes. Delegate Morgan, okay, now your hand is up. I see it. Delegate Morgan. Oh, you're voting against. Okay. Okay. All right. Anyone else? Okay. Seeing that, the bill passes. Thank you very much for your work. Thank you, Delegate Bagnall, for this. So I want to move to House Bill 601. And when we spoke last on this bill, we were talking about trying to limit the impact of the bill to a particular section of the code, and particularly around things like cost reimbursements and what pricing lists were used that we currently have in our statute. I learned late last evening that there was a significant issue with that, because with that approach, because it would require the definition of purchaser to be different in two different sections in two sections of the same code, and that could not be achieved. So what I would like for us to discuss today is if there is any resolution to that issue. Can we find the language that permits our pharmacist, or permits us to regulate PBMs that serve ERISA and state and local programs to come under our regulations around the reimbursement policies. So that's what we're looking for, and would like to hear from folks, the MIA, Delegate Kipke. I'm hoping that there's a way forward here so that we can make some progress. I'm going to start. So I think, Van, I'm going to start with you so you can help us understand what the issue is, and if you have thoughts about how we might address it.
Sure, and I do have thoughts on how to address it. One of the issues is that throughout these various sections, the phrase pharmacy benefit manager is used, and that, of course, is a defined term. And in the definition, it refers to an entity that performs pharmacy benefit management services, which is also a defined term. And when you look at that term, it uses the word purchaser, and the word purchaser that is used in that section is going to be the word, the definition that's in 151601. So what you end up having is, and if you define the word purchaser in a narrow sense, then you're going to have an argument that PBMs that only act on behalf of self-funded plans are not subject to the various particular sections that you're trying to expand. So I think the easier way to do it, and the way that frankly is more consistent with the Arkansas law, would be to carve out those sections that you don't want to apply to those PBMs that are acting on behalf of only self-funded plans. And there's a way to do that, and I think we can share language with this. We're still working on that, but we should be able to share language in that regard. But what you would do is you would define the word carrier in 151601, and with regard to that, that would be the entities that are subject to that meet the definition of purchaser currently. So they would be an insurer, a nonprofit health service plan, an HMO, and the state plan. So those are the four entities that would constitute a carrier. And then with regard to those sections that you are concerned about, you could then prop in the term carrier. And here's an example of how you would do that. I know, for example, PCMA in their letter mentioned the therapeutic interchange issue and thought that that might be a section that might be problematic. So if you were to do that, what you could do is, and that is part Roman numeral 4 of the existing statute. So what you would do is you would create a new 15-1632. And in that, you would say that, essentially you would say that part 4 of this title only applies to pharmacy benefit managers providing pharmacy benefit management services on behalf of carriers.
Okay.
So, and then that section then is limited to those PBMs that are just carriers. Now, what that would also mean, though, is that essentially all PBMs in the state would be required to be registered, and they would be subject to the enforcement provisions, which also makes sense because in our view, it doesn't make sense to have some PBMs registered and some not, and some subject to penalties and some not. And so that would alleviate that problem as well. And there may be other sections that may be of concern to PCMA, and we can hear from them. One might be Part 3, Roman numeral 3, which is the Pharmacy and Therapeutics Committee issue. But the only other thing that they mentioned in their letter I saw was the audit provisions. But I'll note that the audit provisions are similar to what's in the Arkansas law. In Arkansas, they refer to it as the Audit Bill of Rights. So it's already in existing Arkansas law and was not overturned by the Supreme Court.
Okay. Questions, responses? Mike Johansson.
Thank you, Madam Chair. And I think we appreciate Van's comments a lot. I think the approach, however, we would suggest go differently. So Van described how you can either create a new part or, in our suggestion, maybe a subtitle, and then apply certain provisions to a different set of purchasers. We would suggest doing it the reverse of way Van said, which would be to create either a new part or a new subtitle for the new set of expanded purchasers that we're talking about, which are ERISA plans, and Madam Chair, you wanted to include the local governments, et cetera. So that new group of purchasers would be defined as a group. We can figure out the right word for that. And then place in that new either part or subtitle the specific provisions that the subcommittee chooses to place there. For example, MAC pricing and GER have been previously mentioned. Our concern with Van's approach is if you broaden the definition of purchaser to be the big group in the existing subtitle, then we're left with the same problem we've all discussed, which is what is ERISA exempt and what isn't. And the question of this committee either deciding each one now, case by case, walk through each one, let's hear the merits, or do we avoid all of that confusion and put the specific sessions that the committee wants to put subject to that expanded definition of purchasers, whether it's MAC, GER, or something else, in its own subtitle that avoids confusing the current law that has been long-standing on the book. So in a sense, it's the opposite approach of what Van talked about. And we are working on a concept language as well that we can kind of share with MIA to get their response on it.
So I have a question, Mike. I know that the court's decision prohibits a special ERISA law for PBMs. Would your approach bring us dangerously close to that?
I think the complexities of this area are many, right? But because it would not be, because you want to include those other plans, the local government self-funded plans, in our view, it is a group of purchasers that may include ERISA plans and those other plans. So it is not specifically drafted to be only ERISA plans. So in our view, we would survive that legal discussion. But again, I think you hit on the complexities of this entire field, and we have to be a little careful.
Okay. Thank you. I have Delegate Bandari.
Thank you, Madam Chair. If I heard Van Dorsey from MIA correctly, this bill will ensure that these PBM plans are subject to regulation by a state legislator, and it will help to regulate the industry in more like uniform way, and it will create the level playing field. Is that the one you mentioned? Van, did I hear you correctly?
That's right. Yes, that's the intent. That's what we're seeking to do. At least with, you know, a narrow part of the statute. Okay. Heather?
Thank you, Madam Chair. I just wanted to follow up since we last chatted. We included, per your request in the packet, you should have received a legal memo that PCMA requested from our outside counsel that does essentially three things. It overviews the Rutledge decision, what the court said and didn't say, it overviews what the Arkansas law at the center of the case sort of pivoted around, and then towards the end, talk about the interpretation of how Maryland's PBM law would be preempted in some instances by the ERISA law. And so hopefully that will be helpful as we kind of go through and trying to understand not only the scope in terms of like which plans would be potentially affected as a result of Rutledge, but also the principles around plan design and central matters of plan administration that the court sort of made a point of discussing and talking about what the Arkansas law touched and what it didn't. I mean, we've talked about it many times before, but I just wanted to call out at the end of our memo, it sort of highlights a few examples of the Maryland law that they believe ERISA would preempt, things like affiliated pharmacy section of the law, the Pharmacy and Therapeutics Committee portion of Maryland's law, the disclosure requirements between PBMs and their clients. And so hopefully that will be helpful to you. And of course, you know, if you need anything more or have questions about that, we're happy to help.
No, thank you. Thank you for providing us with that, because I think that is can be a guiding document. Jim Doyle.
You're on mute, Jim.
Yeah, Jim, you're on mute.
Okay, can you hear me now?
Yes, we can.
Okay. Since the issue of the memo provided by PCMA, the trade group for the PBMs, has apparently come up and is potentially leading to further amendments, I wanted to comment on that memo, which I had the opportunity to read this morning. And of course, I've also read the Rutledge opinion a number of times over the last several days. The point I would like to make is that having read the PCM opinion, legal opinion, it is clear to me that that opinion badly misconstrues the law as set out in Rutledge. Rutledge, the PCA memo takes the position basically that Rutledge simply has said, well, if you have a cost regulation, that's something that's not going to cause a problem. So that's all we need to be concerned about. But if you look actually at the language of Rutledge, and it's throughout Rutledge, it's not just one sentence, it's a number of occasions where the court, in its opinion, talks about what its theory is. Rutledge clearly indicates that there is not an ERISA problem unless the state law forces a state to adopt a specific substantive benefit. So, for example, if the state law.
So Jim, I'm sorry to be rude, but we do have a time constraint here.
Okay.
I don't want to re-argue the case over this interpreting the scope of Rutledge, because where the wonderful delegate came to with me is it's very, very clear to me in Rutledge around the openness of the reimbursement rates, the kinds of, so a narrow scope. There may be more scope to that, but I really believe that if we were to open it up to the whole scope, we open the state up to litigation. And because I became familiar with the Rutledge decision when I was doing some work with NCSL, and I knew right away we were going to be seeing, legislation that was going to be testing that out. And I am very willing to test out the piece around the financial aspects. And there's financial, but there's also registration. There's also, the filing of contracts. So those things are still going to happen under what I am trying to accomplish here. But I'm hesitant about opening it to a broader scope because I'm hesitant about making it likely that Maryland will find itself in court over litigation, trying to define the Rutledge decision. So we've agreed to disagree that there's what the scope of Rutledge is. Or at least I hope we have agreed to disagree on that. And what we're trying to do is make the best of it by finding a piece that we know works and that we can implement and we can take a year to watch the rest of the nation as they try to test out the limits of the decision, which I'm fairly certain is going to happen. So, please let's not relitigate our differences around scope. Brian Hose.
Brian, you're on mute.
Yeah.
Madam Chair, I think Steve Weiner might be able to.
Oh, okay. Thank you, Delegate. Steve Weiner, you want to try first until we get Brian off of mute? Or what?
Yeah.
Sound working?
Yeah. So very quickly, and thank you for letting me speak. I appreciate your input. I just want to address one more thing about the PCMA document regarding Rutledge, and I'll let it go. The items listed, ERISA, again, I'm not an attorney, but my understanding is the goal is to create uniformity in the country with plan design, among other things. The items listed in the PCMA document are items that they've not been done uniformly. So they talk about audits. The same payer will have different rules for audits for different scopes of practice. Formularies, they will have different formularies for the same payer for a multitude of plans. So the argument that they're using ERISA to protect payers is ludicrous. They're doing the exact opposite. They're using ERISA to sort of have an anything goes card for whatever they want. And again, I'll let it go. I understand your point of view. The last point I make in what we do, we passed GER legislation 2 years ago. It did nothing for a year because it was fought and then it had to be tightened up in the following year. So if the goal, unfortunately, is to narrow this, and I don't agree with that goal, obviously, and I'm sure PCMA's goal would be for this to include all plans that reside in zip code 21201, and that's it. You know, the insurer has to be in that zip code, the pharmacy has to be in that zip code. But if we are going to narrow the focus strictly for payments, then please let's do it right. Let's not just put a whole bunch of language in with new sections to have the same end result. And that's what appears to be the goal of the other side. Very wordy, but let's have the same end result of a limited scope. And thank you for letting me speak, Madam Chair.
Thank you, Steve. And I appreciate your perspective. I really do. And I think we have made some progress. It's been tough going over the last few years, but we've made some significant progress in our ability to regulate PBMs that don't include the ERISA markets or the self-funded markets or the local healthcare plans, the local government healthcare plans. And what we're saying is we're finding a way to open that up around the financial issues. And because that seemed to be one of the primary issues in all the bills that have come to us over the years about how do we make sure that pharmacists are receiving fair reimbursement for their services. And when this bill came, I saw it as an opportunity to broaden the volume. And that's what it really does. It broadens the volume of access to plans. Where the trick is, and you just mentioned formularies. Well, formularies are part of the benefit plan. So that's not part of what PBM, that's what the carrier does. That is protected by ERISA, at least on my understanding, and the lawyers can tell me I'm wrong. And so the issue with the Rutledge decision is now every state who tries to work on this decision is going to have to parse out what's strictly PBM activity and where does it integrate and intersect with carrier and benefit activity, because that's off base. But the PBM activity is not off base. So I think that's what's going to be litigated over the years, where those trying to determine where those intersections are. But
with all due respect, everything will be litigated. No matter what your intentions are, everything will be litigated because it is. I wouldn't make that your end goal. I'd make fairness and what is appropriate, and I think you are. But if you try and make this litigation proof, then we're going to fail from the start because it will be litigated. You know that, and I know.
I don't know. I actually don't know that, Steve, because when we passed the omnibus bill 3 or 4 years ago, I got told I was going to be dragged into court and I should buy a new suit. And it didn't happen. And we worked together. You sat in those meetings, developing the regulations to implement that bill. And I never had to go to court. So I'm not afraid of going to court. It's just I don't think that at this time we need to put ourselves on the chopping block, somewhat deliberately to test out the law when we can actually help you now by finding the language that I know Van and Mike are looking at to kind of move us forward. Anyone else who wants to, Van? You're on mute, Van.
Sorry about that. Yes, I have a question for Mike and Heather, I think, and that is whether, because I didn't see it in the PCMA letter, and I'm not aware of anything in the case law that would really support an argument that the registration or enforcement provisions would be preempted by ERISA. It's treating the PBMs equally, and so I just want to confirm with them that they agree with that.
Heather, Mike.
Yeah, thank you. We actually had a conversation about that this morning, Van, and someone in our group suggested registration could be an issue, and others disagreed. But I think that issue is going to be up to the committee to make a decision on whether or not to include registration. We certainly understand MIA's interest in knowing who's out there, but it doesn't mean someone won't challenge it. But certainly, if it needs to be included, we understand you all may choose to include it.
And we think it's vital that it be included, to be honest. I mean, there's no enforcement mechanism without it, particularly the penalty provisions. And I'll point out, there's a licensure requirement in the Arkansas law. If they didn't challenge it when they went to the Supreme Court, and then they're going to challenge it subsequently, that seems illogical to me, to be honest.
You and I aren't making decisions for either the logical or illogical people here, whether they choose to challenge it, right? I mean,
I believe the delegates will be making logical decisions. So
I would offer that I suspect that the PBMs who are serving in Maryland, not totally, but those who are serving ERISA plans and self-funded plans, many of them are already registered. So I don't know what that percentage is, but I think so they're registered, so we already have access, and then it's just a matter of picking up the ones who are not registered. So, all right, so I am not seeing anyone with any action right now. I am wondering if it is possible for a group to begin to look at that language, and if we could get discuss the two options that we have here, one from the insurance, one from insurance and one from PCMA, in terms of how do we craft the language that would work. We could meet on this bill tomorrow morning. We would really like to get it, if we could get it through our committee tomorrow, we could get it on the floor on second reader on Saturday. And I know it's a really tight time frame, but I was hoping that, I'm asking whether or not that's a possibility. And Delegate Kipke, I don't mean to ignore you. Would you like to, what are your thoughts? What's your desire?
I don't feel ignored, Madam Chairman. Thank you. I appreciate the work that Van has put into this. Obviously, we want to do it right. So I guess the question would be for he and his team as to whether or not the time frame works for them.
I'm sure you're not surprised. We've already started working on language, and so we should be able to forward language today.
Okay, so would folks be open to an 8:30 meeting tomorrow to look at that language? The committee, committee, you're already there. What do they call it? A captive audience. But I'm looking at the other folks who would be working on the language.
We'll certainly participate, and I have a feeling we can hopefully reach agreement with MIA on the right structure. It's just a question of it's two different places to get to the same, two different ways to get to the same place. We just want it to work. If it's going to be applied to us, we just want it to be working.
Okay. All right. Then I appreciate tremendously. I apologize, Jim. I didn't mean to cut you off, but I really, because I'm on a tight time frame, I need to move things along. Jim, did you have any final words or did you just not take your hand down?
Oh, I'm sorry. I just didn't take my hand down.
That's okay. I thank you all for your participation, for your willingness to work on this, and I look forward to, I'm hoping maybe like an 8:30 meeting tomorrow where we can hammer it out with the subcommittee. The subcommittee is giving me the evil eye, I have to tell you, but we'll survive. Delegate Lewis Young, are you saying something or just no? Okay. Okay, then thank you very much. That concludes our work for now on 601, and we will try to get it out tomorrow. And we are going to start on House Bill 565, which, so let's, and this discussion is with the subcommittee alone, and that's health facilities, hospitals, medical debt protection. And for this, we have Aaron, whom I owe many meals to. That I spent on this bill, Aaron spent 10 more. So thank you. We went through a reprint together, I think it was on Tuesday. And what the reprint that you got today reflects our response to your concerns. So we tried to respond to as many of the concerns as we could. And feel like we had a viable bill. I've had a sort of a personal reckoning with this bill. Those of you who know me know that I constantly seek consensus. I look for things that, folks can agree to. And my epiphany was, this is not a bill that it's possible to do that on. And the reason is, and it's a pretty clear reason, because the stakeholders have different goals and different missions. So the hospitals are required to charge people money for their services. They're required to try to collect money. When they can't collect it, they have to have tools in their toolbox to help them collect it. On the other hand, as the End Medical Debt Coalition is saying, is we want to make this process as humane and compassionate as possible. And I honestly believe that what we're bringing to you today gets us very close to that. It will never be perfect. As long as medical costs are as high as they are, unless you are wealthy, and they're always going to be a challenge to pay, even those who are 1,000% of the federal poverty level. So we need to find the way that we can be most responsible, that the hospitals can be most responsible in reaching out and trying to collect on that debt. So we've made a couple of substantive changes in the bill. What I'd like for us to do is Aaron is going to tell us what the changes are, and then we'll discuss those changes. And hopefully you will adopt the amendments, and then we can have a discussion on the bill. So Aaron, if you want to go through the amendments since the last time we saw.
Since the last meeting. So the biggest thing would be page 6 of the bill after line 22. And now the payment plan, the HSCRC would be developing the guidelines for the payment plan with input from stakeholders. So at the last meeting, it was the hospital through their patient advisory committee.
Right. So I went back after our last meeting to HSCRC. I was literally begging, but they were very responsive, and they agreed to work with expert consultants to pull the group together and develop a plan that will do what I was saying, that we need something that is humane and compassionate and is not putting a significant financial burden on the patient and the person who's paying the bill. There was one other change, which is relatively substantive. The HSCRC needed this if they were taking on this role of developing the plan, because just finding the right expert. So they said if the hospitals delayed all collection activities until the plans were ready, they would struggle with that, because they're the ones who have to set the rates, and they set the rates based on how much a hospital has made in any given year, what their services have been, how much they've collected, and so they couldn't put that off. But what they could put off is legal action. So no legal action could occur until the plans are implemented by, from the HSCRC. So that was one change they asked us for.
And that's in 3(3). If
Pardon?
you just, I'm pointing to the bill in the reprint.
Oh.
That's in 3, where I spoke to before after line 22.
Yeah.
That's 3 Roman 1. If you go to 3 Roman 3, it used to say a hospital may not seek debt collection. Now it says a hospital may not seek legal action until the payment plan guidelines are developed. And then for the stakeholder input, if you look in your reprint, there is on page 13, after line 17, that states who the HSCRC would be required to seek input from. And it's the MHA, the MIA, Office of the Attorney General, labor unions that represent the healthcare sector, a statewide nonprofit consumer rights group, patients' rights organizations, legal services providers who work with patients who have experienced medical debt, and patients who have experienced medical debt. And then the HSCRC would be required to report the guidelines to Senate Finance and HGO. And that's by January 1st, too.
2022, right? That was the other concession we had to make, was to make it go out to January. I know, Delegate Bandari, you had a list of about 20 people that you wanted included in that list. This has to be a workable work group. And so what we looked at in terms of that list was the people who have absolutely the most direct experience with people who are experiencing medical debt. So, a legal, and in fact, this was mentioned in our last meeting, that you want somebody who who's providing legal services to those who are experiencing medical debt. And so we made sure that they were there. We made sure that patients were there. So we believe that this group will meet the needs of that, providing the information that the HSCRC and the expert consultant will need in order to develop the payment plan. Okay. Anything else, Erin? Did I leave out?
I think those are the major changes since
the
last meeting.
So let's talk about these amendments and see what questions people have. Delegate Krebs.
Thank you. A couple of very good changes. I thank you about the hospitals being able to continue on their debt collection. They just can't take legal action. I'm not sure how they are with that, but they obviously need to be able to continue to make calls and set up payment plans. So it's definitely way better being able to do that. And then the other one was much better as well. The one question I had, codified section, it talks about labor unions being part of these, developing the guidelines. I'm not sure at all why the employees of the hospital are developing debt collection guidelines. There's not a nexus. I see the patients and I see hospital association, insurance administration, attorney general, but I have no idea why the employees, certain employees of the employer are involved in this debt collection thing. It just doesn't make sense.
So the reason for that is it's not the employees of the hospital, but rather folks who represent people who may be experiencing hospital debt. People who, most labor unions represent folks who are not wealthy. I mean, we have in Montgomery County in our public schools, the folks who do, who are professional services, many of them qualify for free and reduced lunch because of the salary that they get. So the labor unions are there because they represent a broad swath of people who may be needing the services of the to meet their medical debt. So that's.
And I would argue that even though people make low wages in the services you just talked about, they have fantastic benefits. So I would argue that people that have labor unions have some of the best benefits of anybody. So they're sort of skewing it a different way because they do have really good benefits. So I don't know why, again, I don't know why. I understand on the salary issue maybe, but if you look at the total package, in general, they make way more money than the average person in the same industry because of the benefit packages. So I just don't see why they're involved particularly, and not just the rest of the people that really don't have a voice, because they're the people that don't have a voice.
There are other folks there, you know, the other folks who have had, who've experienced medical debt. So again, the labor unions are representing a swath of people, whereas the individuals are representing themselves.
But they're not representing uninsured people, because I doubt very few people belonging to labor unions are uninsured. And then some of these people are uninsured or have high deductible plans or whatever, or paying as you go. And they're the ones that I think are, I don't know, there's no real data to show you who these people are, but they have some of the best health insurance, I believe, at least all the unions I know. You mentioned school systems, they have some of the best, the state employees have some of the best health insurance that's available. So I don't think they're the people that are going to be falling under this, debt collection, but I don't know. I don't have data to show that, but just intrinsically don't think that they're the ones that are having problems.
I hear you. Delegate Lewis Young.
Thank you, Madam Chair. And thank you to both you and Aaron for all of your hard work. There's definitely some significant improvements here. In fact, I only have 2 suggestions. They're word changes, and they're both on page 6, which is very minor. The other one a bit more complex, so I'll deal with that first. Section 3, it says for an income-based payment plan. Here's my problem with income-based. I'll give you 2 examples. Single parent, income $50,000, mortgage payment, car loan, education loan, 4 children. Another person lives with a spouse, with in-laws, no debt. Totally different scenario. And I don't think by saying income-based, it takes that into consideration. I want to just mention something about credit practices, and I promise I'll keep it under 2 minutes. Credit decisions are made based on a number of variables, but they fall into 3 categories. Income, a concept called debt burden. How much debt do you have already? And how is that a portion of your income? And what is your credit history? Do you have a pattern of being late and delinquent? Or have you had unusual circumstances that are very isolated? And so instead of saying income-based, I'm going to suggest, and if you can find a better word, that's fine, affordability-based. I know down towards the bottom of the page, there's a reference to a definition of financial hardship, and Erin was kind enough to send me that. And while that definition does explain the number of dependents you have, it doesn't look at what your other obligations are. And particularly if longer term court action will be taken, then I truly believe we need to assure that we give people a payment plan that's reasonable and affordable.
And I agree with you completely, Delegate, but I believe that's the purpose of developing the policy around the repayment plan development. And in fact, they would be, I feel pretty certain after talking with folks from HSCRC, those are the kinds of things they would be looking at. I mentioned the geographic and environmental impact. And one of them said, yeah, we could ultimately look at bands, so of income related to where you live. So this policy, the reason I am worried about changing it from income-based, because then it could tap into assets, which we don't want to do.
Right.
We want to just keep it on what you can pay based on what your income is. and all the other considerations that go into that.
Yeah, as long as we can address that. And then I have just one other very simple suggestion on that page.
Okay.
At the bottom, section A, where it says the determination of possible interest payments. Could we insert possible market rate interest payments?
But do we have to, would that put us at risk for it being higher than they might actually decide?
Well, I suppose so, but I just want to make sure that if kind of the average interest rate is 5%, that there aren't interest rates of 23%.
Right, no, and I've been told by hospitals, and the bill came in, I think, originally with a 1.5% interest rate, and
Right.
at being the top. And
Okay.
basically they said to us, that's about where they are. If they charge, they don't always charge interest.
Right.
So,
Okay.
and we, in this bill, we've prohibited interest on anybody who qualifies for reduced cost care.
Right.
So
right.
we've hit one cliff, but not the other.
Okay.
Okay.
Thank you very much.
Thank you, Delegate. Delegate Bandari.
Yeah, thank you, Madam Chair. Thank you for your hard work and commitment, working so hard on this bill. I'm really happy to Delegate Scribb question. Yes, absolutely. The unions, they always fight for fair wages, benefits, and better working conditions. The intent of the bill is to protect low income and working families. So I think we must have to put the labor union there. They will have more advocacy to that end. And another just a comment, like last time I raised it, if possible, it's not hard to ask, Madam Chair, if possible, if we could restore reduced cost care, throughout the document, if possible. It was in the original bill, but I think it moved out. So if it is possible.
I don't believe that it is, Delegate.
Okay.
And the reason is it simply expands the pool of funds that can't be collected.
Okay.
And as we spoke, one of the things that I am hopeful is that all of the things we have put in place to help them identify those who qualify for for free care and reduced care and then we have reasonable payment plans based on a lot of factors that go into their ability to pay without creating a financial hardship. I'm hoping that we will get to the needs of that window of people between 200% and 500% of federal poverty level.
Understood. Thank you.
Thank you for your question, Delegate. Delegate Krebs, is your hand still up? Or are you just?
Yeah, yes, it's still up. I have
Okay.
couple other questions. I see on page 8, it says a hospital may not request a lien against its primary residence in an action to collect debt owed by a hospital bill. Get that.
Mhm.
The part that you talked about, I can't see that, is the income versus asset base. So is it in here somewhere else? It can't go against any other assets. Can be your bank account. It can be your CDs. It can be other wealth. So where is it?
We didn't address that except in that first part where we said that the repayment plan had to be based on their income, not their total assets.
So why is that? I mean, some people have a lot of assets and they might temporarily not have income. And it just seems to me, keep in mind, we're not talking about making hospitals flush with cash. We're talking about keeping our rates reasonable and people paying what they're able to afford. And there are people that have a lot of assets and they don't have a lot of income. So I don't understand. I understand that not being able to go against the primary residence, and I think that's good. If they have assets, why shouldn't they pay their debt?
They're relying on those assets for their, their day-to-day basically, or their future. So I think, what we're trying to get at, I think that payment plan issue will enable us to collect the money that's owed in a reasonable way.
But when you just said, what you just said to me, we don't know. I think we're assuming people are all sort of the same. And there have resources. There's people that have lots of bank accounts. There's people that have savings, not necessarily retirement, but it seems to me if you owe money, your credit card company, if you owe money or you owe money on your house, they're not going to say, oh, I'm not going to make them pay their payments because they don't have income when they got $100,000 or $500,000 sitting in the bank. So I think we're tying our hands of reasonably collecting money that people owe, just because they might not right now have, for whatever reason, a cash flow, or maybe they never have a big cash flow, but I don't know. I just don't, again, the primary residence, I get that, but it seems like there should be more structure. If somebody's got resources, they should pay their bills. And then that's my first issue. And the second issue is the hospital not making a claim against the estate of a deceased patient. There are a lot of people that die in hospitals. I mean, people get sick, that's when they die, their end of life. And there's a lot of people that have assets. It's my opinion that people should take care of their debts, and it's not necessarily their family's inheritance that I'm worried about. It's taking care of the debt that they owed. So again, they don't usually go back against your primary residence for that either. It seems like an estate, if you've got the resources, should pay your bill. And it shouldn't just be wipe it out now because I died in the hospital, because a lot of people die in the hospital at the end of life and have assets. So that is a big deal to me. I don't know what other debt that we do, whether it's credit cards or anything else. If you have a mortgage on your house, where else do they say, oh, you die, your mortgage is paid off, or oh, you die, your credit card's paid off? And again, all this uncollected money, because my dad died last year. Should he have not paid his hospital bill because he died? We had the resources to pay it. I mean, why? I mean, I wouldn't think for a moment on someone that could afford, I wouldn't think for a moment, oh, go wash my debt off and let someone else pay it in uncompensated care that's going to drive up everybody's insurance costs. I just don't think that that's reasonable. I mean,
Okay, I think you.
Okay.
Did you have another point? I mean, I think that.
Well, they're the two things that are left.
Okay.
The income versus asset based, and then not making a claim against the estate of deceased payment to collect debt.
Okay. Delegate Kipke.
I was just thinking about something. If somebody has a payment plan and they die, can under the language of the bill, can the remainder of their balance be collected from the estate?
I don't think the way it's written now that would be allowed. Aaron, what do you think?
Well,
No,
so let
okay.
me give you an example. My uncle died last year, and he has no wife or kids, and but he had a lot of money in his retirement and in his house and all that. Anyway, my aunt got a letter saying, we want to collect on Medicaid, actually, that the state is able to collect. And so it was an $8,000 bill that she paid out of his estate. And so all the money that he has left is being divided up among his brothers and sister. So in a situation like that, it's certainly appropriate that a collection can be made. However, I'm obviously sympathetic to folks that, have kids or, there's a whole other. So I think there has to be a way to handle this in a way that you look at somebody's situation. I don't know if the HFCRC can help us with that. I mean, obviously that's a very complicated thing to figure out, but I think it's important that those types of collections that can be made where there's no harm should be able to move forward.
I think I'm wondering if I'm just thinking if in the calculation of the repayment plans, we could ask them to look at whether or not there's a way to include assets in the calculation. But so it would put it off, as they're developing the plan, but it would be something that they could look at. What's the committee feel about that? What do we?
Madam Chair.
Delegate Bandari?
Thank you, Delegate. Keep it a very valid point. But what we can forget here is It is about protecting the vulnerable people. So I think that that language should be there. And if there is a problem, and the agency can suggest, and we can come with another bill and fix it if there is a problem. But I do strongly oppose that idea of, eliminating that section, because this the whole intention of the bill is protecting the vulnerable people. Like when we take their home, their kids, and like a lot of problem here. So there might be a couple of people like that, but majority of the people this bill is trying to address are different groups.
Have you taken a poll of how many people? Do you have any data to suggest that what you just said is accurate? Why do you believe that it's mostly the vulnerable?
Because thank you, Delegate Kipke. There is a data how many people were being sued and their situation and the poverty level in every counties. There's a hospital they have sued. And look, Delegate, to your answer, these are non-profit hospital and the government helped them. And we don't know how much they are getting from the government as well. It's not clear. So I think I strongly believe that that section, Madam Chair, should be there. I don't disagree with you. Yeah, very convoluted issues. That might be a discussion for another bill, or we might have to amend later. If we want to, we are trying to find a compromise here, Madam Chair.
Thank you, Delegate. Delegate Saab.
Thank you, Madam Chairman. I disagree with Delegate Bhandari. I think the language should be there because I think hospitals forget that we pass bills to help not just one section or population. We try to help bill and try to be fair and balanced. And by adding this language in it, because people, if you receive the care, you should be able to pay for the care, whether you're alive or you're dead. And it's unfortunate because the hospitals, they could be nonprofit, but they're there providing the care. Their job is to get paid at some point, because at some point, if they don't get paid, all that money goes to uncompensated care, and then everybody else have to pay for that. So if we want to be fair and balanced, I think we should have some sort of language to protect some of those people that can't afford to pay it.
Then I'm going to go back. Oh, well, let me see here. Delegate Kelly.
So I think I may be about what you were about to say. I hope. I want to go back to clarify what your suggestion was, because I think you were on the right track, that there's a potential solution for this that is also language we could adopt now to not hold the bill up, but would get at the crux of what Delegate Krebs and Delegate Kipke were getting at.
Well, that's right. That's what I was gonna reiterate my suggestion.
I was with you on it, so go ahead.
And the suggestion is that in the language regarding the development of the repayment plan, that one of the considerations is how estates and other assets might be considered in that policy. Is that?
Yeah.
Collison, the one group that hasn't weighed in on this is HFP, and I'd like to understand what
I'm sorry, I didn't understand, Delegate Krebs. You said the one group that hasn't weighed in.
Well, that I'd like to ask about this, the experts is the HSCRC, because the thing that we are unique in is trying to protect our unique rate paying system, and that's right. Sort of what I'm worried about. And they really haven't weighed in. I don't even know what is common practice with hospitals.
But Delegate Krebs, I did ask them about this before we struck it.
And before you struck what?
I was told that it's not used very often, and so it wouldn't have a significant impact.
I'm talking about the estate. There's two issues. One's the estate, and one is the
estate piece is the piece I asked about.
Okay. And
the other assets, but they
deceased. So they don't think that when somebody dies, when somebody dies, they don't have to pay their hospital. That's common practice now.
That's not what they said to me, Delegate. What they said was prohibiting hospitals from making the claim against a state would not have a significant impact on what is now being collected, because it's not a tool that's used very often. So they did not that was not where their greatest worry or concern was.
Did the hospitals agree with that statement? I mean, again, is that a fact?
The hospitals do not agree with this. No, the hospitals, they have recommended other language, but my sense is, as Delegate Bandari has said, we're trying to address the issue that that a lot of medical debt rests on folks who are over 500% of federal poverty level, but they do not have a lot of wealth. Because if you think about what 500% of federal poverty level is, still not a lot of money.
But we don't know,
these
I mean,
bills are very high.
well, I guess what I'm asking is, and the hospitals would know this. I'm not talking about the people that are poorer, but right now today, do hospitals make claims against the states of deceased patients to collect debt? No, we're basically saying nobody has to do that anymore.
Correct.
In the future, period. So, I mean, I'm not talking about uncollected debt. I'm talking about today, hospitals will not be able to collect debt from someone after they pass from their estate. And people pass in hospitals all the time. And I think that would be terrible. And it's a new policy. I mean, it's a new policy. And
Right.
again, I talked about my dad who had very high hospital bills and we paid every penny of it and we wanted to, but why should you not? Just because you passed away and you now can't,
Right.
Why should you be relieved of that debt?
So what I'm suggesting, though, is that we take a look at that. The bill doesn't go into effect until next January because so we can definitely ask HSCRC to consider whether or not that, how that might work in the collection tools, that in a way that doesn't penalize people who cannot afford it or take away, like, for example, the gentleman who came to speak to us about, how he lost his home because it was his mother's home. That was the only asset she had. And he lost it because of, essentially he lost it because of 15 years of interest or something. It was a long time interest. And then we don't want to put people out of homes. So I'm suggesting we look at it, we consider it and have them look at it. And until January, if hospitals are using this, they can continue using it. Won't go into effect until January 2022.
Well, and we do have language in here protecting a primary residence.
Right.
So if it's their children living in it, they need to make, alternate. So why don't we leave it out until we come up with the information, then put it back if they think it's okay?
I guess I'm advocating that we, in a good faith effort, to say that we're trying to watch, to take care of those who are most economically vulnerable and leave it in there. With the caveat of, let's look at it in the repayment policy. I'm going to go to Delegate Bandari.
Yeah, thank you, Madam Chair. I do strongly agree. Agree that these lawsuits were 3 times as likely to take places in low-income neighborhoods. So again, I'm repeating the fact that this is for vulnerable people. If we need to help hospital, we need to help hospital as well. And thank you, Madam Chair. I do 100% agree with you.
Thank you, Delegate. Delegate Kelly.
Thank you, Madam Chairman. And I always agree with you. And I'm tending to agree with Delegate Krebs on this one. I'm really concerned. And Delegate Kipke, whom I love, said something that concerned me even more. I'm on the different end of the ideological spectrum from them. To the point where I really don't believe anybody should be able to transfer wealth at death. That's my personal opinion, because I think there's so much income inequality in this world. And I would really hate to see folks slipping through the cracks who had wealth to pass on to people, but they're slipping through the cracks and it's ending up in our uncompensated care. That terrifies me, because I think what we need to do is eliminate wealth inequality. And so I just really want to make sure that the timeline that we have in place is not going to allow folks who have wealth to pass on to their heirs to not pay for their care if that is eligible. So I'm really concerned about this, and maybe I'm not understanding the timeline correctly, but what you explained was that it would go into effect January of 2022. Right. So we would not have time to act on this,
but
right?
In the meantime, the HSCRC, if they're going to give us a report, right? And based on what their expert says around the repayment plan. So we will have that information for the next session. And if then in that report, they recommend that there has to be some sort of asset test, then, we can follow up on that pretty quickly.
So it would be, because there's two different implementation dates, right? There's an October one and a January one, or it's all just January now?
It's all January now.
It's all January, good.
Right.
So we will know by January if we need to act in some way to make sure
Right.
that folks aren't slipping through the cracks in terms of an asset test.
That's my belief.
Okay, thank you.
Okay. Delegate Lewis Young.
Thank you, Madam Chair. I'm going to reiterate part of what Delegate Bhandari said and what you said. This bill was developed to help the most vulnerable among us who don't have income or are income constrained, don't have assets, don't have wealth. We can't always develop policy for the 1% of the population that might try to beat the system. And this is a really complex bill. We can't anticipate every what if scenario in this bill. And I think one of the greatest improvements was the chair's effort to work with HRCRC to bring in experts and stakeholders and develop policies to fine tune some of these scenarios. So I totally agree and support the chair's recommendation that this is an issue, an exception scenario that we let them deal with.
Thank you, Delegate. Delegate Carr.
Madam Chair. So just wanted to beat a dead horse and bring up again this issue of the threshold, just based on my personal experience where my wife had a debt of $75 at Hopkins Suburban Hospital.
Yep. Delegate, we've lost your sound.
Can you hear me?
Now we can.
So yeah, my personal experience, my wife was sued by Hopkins over a debt of $75. We were trying to evade or not pay, but just it was a problem with the claim that was getting straightened out. But their system was to just file these lawsuits en masse, and they don't even file them. I think they just upload them. They have a giant database or spreadsheet of all these debts they're owed, and they send them in bulk to the court system. So that's been their practice. I was told by Hopkins they raised their threshold to $300. So they have an internal threshold by which they don't sue people. So they're already living by such a policy. So I think it would make sense for us to have a similar policy in the statute where we set a threshold by which they should not sue.
I appreciate your comments, Delegate. I do believe that that is the element that kills the bill. And that if we want to help poor people in any way, in all of these ways that this bill does, we need to move this bill without that piece. And I am confident that after the year of implementation of this bill, and be careful with what I just said, after the year of implementation of the bill, remember the bill everything doesn't go into effect until January of 2022. So we are putting it off then. But we are going to gather over this year information about the impact of medical debt on people who are, different racial categories, different income categories, different insurance categories. We're going to get all of that information based on this bill. So we'll be able to look at that piece after this bill has had a chance to work. But I am confident that it is the piece that will not be accepted and cannot move forward and will kill the good efforts that people are trying to make here. Delegate Kerr.
Thank you, Madam Chair. Yeah, I do hope that we do get some information in that report that helps us settle this issue of the threshold, because I too think it's important, but I don't want to jeopardize the bill. But what I asked to speak on is the estate. Just one more point to make. I think the distinction that's not evident in the text of the bill is an estate that has dependents versus an estate that has heirs. I think we want to protect the estates that have dependents, but the objections that Delegate Krebs raised about people not being able to pay their debts, if we're not going to put someone out of a home, and there are debts, but again, I want the bill to move forward, and that's something that we can, hopefully the report will reveal for us when we hear it in January. Thank you.
Okay. Delegate, thank you, Delegate. Delegate Saab.
Thank you, Madam Chairman. So I've heard like some words, 1% and what if. I think what we do, we do come up with policy on a lot of what ifs sometimes. And we also legislate based on a lot of the 1%, and we don't legislate based on one personal experience. And I think many of us, whether in subcommittee and committee, want to support this bill. But if we can, we also want to make sure that we support a bill that is fair and is balanced. So, I think some of the suggestions that were made before, if they're in the bill, we're going to get a lot more support than just keep getting the pushback on, the what if and that. So obviously we're not voting on this today, but I want to strongly recommend.
Yes, we are, Delegate.
We are?
We
Okay.
are voting on this today. Yes.
Okay. Well, I mean, like I said, it's not a good policy to legislate based on 1 or 2 or 5 personal experiences. There's good apples and bad apples, but there's also, we can't just base it on, to help 1% of the population. I think we need to look at the bigger picture. But I just want to make a statement.
Okay. Thank you, Delegate. All right, so I'm going to go to Delegate Bandari, and then I'm going to call the question.
Thank you, Madam Chair. I do agree with Delegate Saab there. We want to move this bill. And I will, thank you so much for your hard work. And I do strongly believe and trust on your wisdom on this one. And I don't want to really kill the bill, putting the threshold there. And another just the comment is, if the hospital will be impacted because of the bill, it would be better if they could send us the impact studies, how much they will lose, and we can find out or have another bill and to help them as well. At the end of the day, we need to help them, our institution as well. That might be for the conversation for next year and the following year.
Okay, but remember, we're going to give this bill time to work. Okay, so let me ask it this way first. Is it the will of the group to add something to the development of the payment plan that considers assets, total assets, as well as the value of estates in the considerations of how hospitals can collect on debt?
How do we raise our hands, or?
If folks would like to see that added, please raise your hand in the participant panel. Because I can't.
Assets or liquid assets?
I said assets because that was, I saw a lot of the conversation going. So that would include liquid assets. Okay. All right. All right, I am not. Okay, the bill has, or that motion only has 4 votes. So we won't include it in this bill. I suspect it will.
Madam Chair, it had 5, but that's okay.
Oh, okay.
Still lost, it's
5.
5.
Okay. Okay. Then I'm going to ask if I can have a motion on the amendments to this bill.
Move the amendments.
Second.
Those in favor, is there any further discussion on the amendments?
Can I?
Delegate Kelly?
Really briefly, I just want to thank you. This has been backbreaking work for you, and we know how hard it is. And I am really applaud all of the work that you have put in on this, and I'm so grateful.
Oh,
That's all.
thank you. Thank you, Delegate. I appreciate it. It is a great cause. So anyone who needs to vote against the amendments, please raise your hand in the participant panel. So you're voting against the for is no hand in the panel. Against is hand in the panel. I am seeing no hands in the panel. Okay, so the amendments pass unanimously. Can I get a motion on the bill as amended?
Move the bill.
Second.
Second.
Can I get a motion and second? Any further discussion on the bill? Are you raising your hand, Delegate Kipke?
Yeah, sorry.
Okay.
I'm going to vote against the bill in subcommittee, although I'm going to take another look at it before we vote on it in committee, hoping that I can get around to a yes. But and I do appreciate the work. This is a huge compromise for a lot of people, and it's been difficult, which is, I love compromise when it comes to things like this, because you want to do the right thing, but you got to be careful about how you do it. Anyway, I too congratulate the chairman of the committee on her work. I know it's been very difficult. I am also mindful that there's a lot of people who care about the bill. I do as well. I think that there's a lot of good in here. So with that, I will be voting no, but I'll take another look at it between now and then. Thanks.
Thank you, Delegate. I appreciate that. Anyone else who wants to discuss the bill? Okay, then.
And Madam Chair, I would like to thank Delegate Kipke's wisdom here as well. Thank you.
Thank you, Delegate. Okay, if you need to vote against the bill as amended, please put your hand up in the panel. Okay. I have to make sure. I have Delegate Kipke, Delegate Saab, Delegate Krebs. Make sure I'm not missing anyone. Okay. So the bill as amended passes. I think we have 11, so it's 8-3. So first of all, I want to say thank you all very, very much. You have really, you went above and beyond in terms of really digging deep into this very serious issue. I so appreciate the time you've spent on this. I know, this is an issue that we're going to be, our awareness has been heightened. We know it's something we're going to have to watch, particularly with, we know that we have high deductible insurance plans now. And to be fair, those high deductible plans are the result of trying to make all the tiers in the exchange work. And so all these things are tied together, and we have to watch out and make sure that people can afford health care. I mean, it is incredibly important. So with that, I would say thank you all very much. And we have finished our work today. So we will be going back on the floor at 5 o'clock today. Thank you.